We are live.
Hello, good evening, everybody. Welcome to Glaucoma module number 18, iFocus number 140. We have Dr. Meenakshi Dhar with us today. She's our very own. She moved to Delhi very recently and she joined us at Center for Sight, mostly at Dwarka, as I believe. She was in Cochin, where she was instrumental in founding the ophthalmology department at the Amrita. It's a multi-specialty hospital where she founded the ophthalmology department and headed it before she actually moved north. She has done her graduation and post-graduation from Maulana Azad Medical College and Guru Nanak Eye Center. As a professor, she has established herself as an astute clinician, not only in glaucoma and cataract, but also in neuro-ophthalmology, in pediatric ophthalmology, in strabismus. So she really likes to describe herself as a pan-ophthalmologist. She's a keen academician, overseeing postgraduate teaching for over 15 years. Her interests include ocular blood flow, normotensive glaucoma, congenital glaucoma, multiple sclerosis, visual fields and OCT in neuro-ophthalmology, and idiopathic intracranial hypertension. She also does quite a bit of toric IOLs and CTRs. She has presented at many national and international fora, including ASCRS, ESCRS, ARVO, WGC, and has been a regular evaluator for instruction courses and free papers at the AIOC annual conferences. She has won AIOS Travel Trainee Fellowship as far back as 1994 and Best Poster Glaucoma at AIOS at Indore in 2019. She also has many publications to her credit. So we welcome Dr. Meenakshi to deliver her talk today on glaucomas associated with increased or elevated episcleral venous pressure. Over to you, Dr. Meenakshi.
Thank you, Dr. Vinita, for that warm welcome. It's a pleasure for me to be here on iFocus Online and being a part of Center for Sight. It gives me great pleasure to present my talk. And this is a topic which is actually, it's a fusion of lots of things which are totally not related. It's just the common factor amongst these is that there is an elevated episcleral venous pressure. What is episcleral venous pressure? It is the retrograde pressure that comes into play when aqueous comes into contact with the episcleral veins. We know that we have the conventional, one second, I'll just try to minimize the, I'm trying to minimize because it's covering part of my slides. Yeah. We know that we have the conventional pathway and the unconventional pathway, and most of the outflow is through the conventional trabecular pathway, where after passing from the trabecular meshwork, the aqueous goes into the Schlemm's canal. From there, it goes into the collector channels, the episcleral veins, and then goes on to the venous drainage system. We know that from when it goes from the Schlemm's canal, it goes into, there are more than 30 to 35 collector channels. From there, it goes on to the anterior ciliary venous circulation. From there to the episcleral venous plexus at the Tennant's capsule and the conjunctiva. From there on, it goes and drains into the superior ophthalmic vein, which drains into the cavernous sinus, which drains into the internal jugular vein, which drains into the superior vena cava and right into the atrium. So why am I going into this? because any obstruction in this pathway at any point leads to an increase in the episcleral venous pressure and causes an increase in the IOP. So we now know that there are different, the aqueous, when it exits through a set of different veins. There is the aqueous veins of the Asher. There is the conjunctival plexus, the episcleral plexus, and the scleral plexus. And all these things combine and then go on to drain into the superior ophthalmic vein. Measuring episcleral venous pressure is, there is no reliable or established method. The venomanometer can be used. More often, it is an indirect measurement which is done. The invasive way of doing it is more accurate, but it is very cumbersome. The non-invasive way of knowing as to how much is the episcleral venous pressure is when a clinician observes the anterior chamber angle by lowering the anterior chamber pressure until the blood refluxes into the collector channels and Schlem's canal, and we can see a small, maybe sometimes even see a small hyphema. Or an examiner identifies an episcleral vein and gradually applies force to collapse the vein and hence theoretically determine the episcleral venous pressure. The normal average episcleral venous pressure is around 8 to 10 millimeters of mercury. It can transiently be elevated with downward displacement of the head. It also increases in supine position. It does not have any diurnal variation. In acute settings, for every 1 millimeter of EVP rise, there is a rise of intraocular pressure by 1 millimeter. The aqueous outflow via the conventional pathway is dependent on the gradient between the aqueous production and its outflow. So if we take this, the Goldman equation, the intraocular pressure is the aqueous humor inflow divided by the outflow facility, and to this we add the episcleral venous pressure. We know that when the episcleral venous pressure is increased, there is an elevated intraocular pressure, and this leads to a secondary type of open-angle glaucoma. There are multiple etiologies, and only once we have ruled out all these etiologies, we think of it as a familial or a sporadic idiopathic type, which is a diagnosis of exclusion. The people who have worked on this as far back as early 20th century, Lauber had tried to put forward the role of EVP in aqueous humor dynamics. Sorry for the spelling mistake. Seedles had observed in 1923 that when Indian ink is injected into the anterior chamber, it reaches the episcleral veins. Asher had first observed the aqueous veins, and in 1968, Thomas Menas and Stephen Podos had first described EVP, and the term radius momini syndrome is is another name which is used by in German to the secondary open angle which occurs along with the elevated EVP. Now there has been a significant linear correlation between EVP and IOP found in both NTG and in primary open angle glaucoma by regression analysis. And it was also found that ocular hypertensives have lower EVP. Then again, the causes of a high episcleral venous pressure, it could be a plethora of things. It could be basically caused by venous obstruction, which could be either due to the presence of a retrobulbar tumor, on orbital amyloidosis, thyroid ophthalmopathy, jugular vein obstruction, congestive heart failure, thrombosis of cavernous sinus or orbital vein, vasculitis involving the episcleral vein or orbital vein, or the superior vena cava syndrome. Here we see a patient of thyroid ophthalmopathy, who has an increased EVP. There is also bilateral proptosis, and one can see the venous congestion and the chemosis. Also, raised EVP can be in situations where there is an arteriovenous anomalies. It could be in the presence of a carotid cavernous sinus fistula, an orbital varix, Sturge-Weber syndrome, orbital meningeal shunts, carotid jugular venous shunts, or intraocular vascular shunts. It could also be idiopathic, which could be either familial or sporadic. Once we need to know the ocular laterality of the condition. We also need to look at the motility dysfunction and also look at the fundus for signs of venous congestion, which are dependent on the level of the blockage. Many of these conditions, as you can see, could be either vision or life-threatening. And when we see something as simple as just chemosis and congestion, we should all find a high IOP. We should not overlook it, and we should try to find out what is, take a good history, try to rule out any history of trauma and history of infections, and do a proper examination. Most of these patients present as a red eye, and the pathognomonic sign is the corkscrew vessels, which are without any inflammations. There are multiple differential diagnoses of red eye, and we need to exclude these out. But this kind of red eye will not get blanched out with the phenylephrine, and the different differential diagnoses, whether it is ataxia, telangiectasia, ACG, scleritis, episcleritis, conjunctivitis, rosaceae, episcleral nodule, all these things need to be ruled out. We should take a good history to rule out amyloidosis, hyperthyroidism, congestive heart failure, hypocoagulable states, vasculitis, superior vena cava syndrome, Sturge-Weber, or any history which will make us think of the patient having a AV anomalies. In the case of suspected elevated venous pressure, there may be a unilateral IOP rise with congested vessels. There could be chemosis, there could be a proptosis, which could be pulsatile exophthalmos, as in CCF. There could also be the presence of orbital bruit, and sometimes patients say that they hear a swooshing sound. Here you can see these different pictures in which you can see the prominent vessels and you can see the angle structures. Their patients may have a proptosis, which may be moderate to severe and which may increase on bending forwards, and we may be able to see hear a bruit, and it may be pulsatile. On gonioscopy, the angles are essentially open angles, and one can see the blood reflex in the Schlemm's canal, or they could be hyalinization of the wall of the Schlemm's canal due to the chronic accumulation of blood in them. Where in the late stages, there could also be neovascularization of the iris or angle. We need to do the ultrasound by microscopy, orbital ultrasonography, a CT scan, an MRI brain, a chest X-ray, and we may even need to do an angiography. We label it as idiopathic if we are not able to find any other cause. While managing these patients, one must address any primary medical condition that might have caused the elevated EVP and would require the specific treatment. Drugs that do not act on the trabecular meshwork should be used as a medical therapy, that is carbonic anhydrase inhibitors. Either of them could be used topically, or if the pressure is very high, use them systemically. Beta blockers can also be used. Of interesting regard is that apraclonidine has been found to be effective in lowering IOP in these patients. Also, since it causes arterial vasoconstriction, which decreases the amount of blood flowing to the eye, it is helpful. The surgery, when needed, a tight trabeculectomy with multiple releasable sutures is the way to go to titrate the IOP decrease gradually and prevent the anterior chamber shallowing during surgery. Uveal effusion-like syndromes have complicated trabeculectomies in patients who have elevated EVP. Sclerotomies with filtering surgery is recommended by some, Prophylactic sclerotomies or scleral windows may be necessary to prevent the choroidal effusion and the suprachoroidal hemorrhage. A follow-up of these patients, we need to routinely follow up as in other glaucomas with visual acuity, with an intraocular pressure, gonioscopy, visual fields, OCT, and the proper referral to the concerned physician or surgeon. Depending on the underlying cause. And the complications which can occur is that some of these patients end up having an acute angle closure glaucoma. This generally happens is when there is venous stasis in the vortex veins. This leads to a serous choroidal detachment or suprachoroidal hemorrhage, which leads to a forward displacement of the lens iris diaphragm and hence causing an angle closure glaucoma. Also, sometimes these patients end up with a neovascular glaucoma once the arterial blood flow has met enough intra-IOP resistance to cause ocular ischemia. Now, we will go through a couple of cases to elucidate the features which are found in each of these conditions because they are totally different. For instance, we start with this patient who came, a 48-year-old male who came with diplopia and redness. He had a gradually progressing swelling and diffuse redness of the left eye of 2-month duration. Patient complained of pain in and around the eye for the last 2 months. He could also feel pulsations in his left eye. There was a history of drooping of the left upper lid in the past, which had improved on some medications. Patients doesn't know what. And also, there was a history of recurrent episodes of redness of left eye. There was no history of ocular trauma or surgery in the past. Patient was a diabetic and hypertensive, apart from a history of CA rectum, which he had been treated for and was admitted for that. This patient had a best corrected visual acuity of 6/6. Patient had an anisocoria, left eye, both the direct and consensual were sluggish. And the patient had chemosis inferiorly. There was corkscrewing of the episcleral vessels. The corneal sensations were reduced. Patient had a 6 mm severe axial proptosis and an eye pressure IOP of 25 millimeters by applanation. Patient bruit could also be seen. Patient had a marked motility restriction and all the levo elevation, levo version and levo depression were markedly affected. The dextro versions were affected to a lesser extent, but each of the motility, each of the movements was restricted. So this patient was a case of unilateral, axial, non-reducible, non-compressible, moderate proptosis, moderate to severe proptosis with ipsilateral restrictive myopathy and a secondary glaucoma. The diagnosis, the differential diagnosis could either be a cavernous sinus thrombosis or a carotico-cavernous fistula. On MRI and DSA was done, and on MRI one could find a superior ophthalmic vein which was dilated, which is seen in this image here. And the patient on DSA, the diagnosis of a dural AV fistula was confirmed, involving the left cavernous sinus with main arterial feeders from both sides of the internal maxillary branches of the external carotid artery. Patient was started on timolol and carbonic anhydrase inhibitors. A neurosurgery opinion was taken and they advised the left carotid massage and close follow-up. According to them, this was not very severe. A carotid compression therapy has been found to be successful in 17% of direct CCF and 30% of indirect CCFs. So this is something which can, patient has to be taught clearly because this is something which can also cause bradycardia. So and on fundus examination of both the eyes was unremarkable at this stage. with a cup disc ratio of around 0.3. And 2 months later, the patient came to us with a non-ischemic CRVO and a corresponding decrease in vision to 618. Patient had a massive cystoid edema or in the left eye. Now, CRVO is known to occur in cases of CCF, especially in the direct CCF, but also sometimes in the indirect CCFs. The cause of the progression from venous stasis retinopathy to the central retinal vein occlusion is the elevation of the pressure in the cavernous sinus. So this patient at this point did not have any visual field abnormalities. After we started the patient on treatment and the massage, the IOP was first controlled and the ocular motility slowly improved. Coming to the CCF, these are abnormal communications between the cavernous sinus and the carotid artery. There is a mixing of the arterial and venous blood, which leads to a decrease in the arterial pressure. So there could be a relative ischemia, and there is an elevation in EVP, which leads to a high IOP. They could be classified as being either, depending on the etiology, as traumatic, most of them are traumatic, or spontaneous or iatrogenic. Depending on the rate of flow, they could be divided into low flow or high flow. And depending on the anatomy, it could be a direct and indirect. The direct CCFs, there is a direct communication between ICA and cavernous sinus. And in the direct, it is between the meningeal branches of the dura and the cavernous sinus. There is a Burroughs classification, which is used very often by the neurosurgeons to determine what is happening. They say there's a type A direct high flow fistula, which results from a tear between the ICA and the cavernous sinus. It is usually caused by a trauma or by a ruptured aneurysm. The type B is between the meningeal branches of the ICA and the cavernous sinus, and it's the red-eyed shunt syndrome. And there are, in the type C, there are dural shunts between the meningeal branches of the ECA and the cavernous sinus. And in type D, it is between the meningeal branches of both the ICA and the ECA and the cavernous sinus. So in nutshell, when we should suspect a CCF when we see chemosis, a pulsatile exophthalmos, and an ocular bruit. These patients may have a decreased visual acuity, prominent facial veins, edema of the periorbital tissues, diplopia, ophthalmoplegia, reduction in the arterial pressure and elevation of EVP, increased IOP, papilledema may be present, and there may be retinal hemorrhages and optic atrophy. The indirect fistulas have a gradual onset and they have milder symptoms. The classical triad is usually absent, and patients usually present with chronic red eyes due to the tortuous arterialization of the conjunctiva. CCF are treated primarily with intravascular embolization and balloon occlusion. There are newer techniques emerging which use transvenous approaches. If untreated, as many as 90% of these patients with direct CCF may lose vision. 20 to 30% of patients with indirect also may end up losing vision. There is good prognosis after treatment. Second entity that we'll talk about is glaucoma in thyroid eye disease. We know that thyroid-associated orbitopathy does see an increase in intraocular pressure. This increase in intraocular pressure could be either due to increased intraorbital pressure, could be due to the proliferation of the intraorbital connective tissue. It could be due to the enlarged and swollen extraocular muscles, and could also be due to the increase in the intraorbital fat, which we know are the common findings which are found in TOO. Also, we have there is an increased episcleral venous pressure, which may be secondary to the orbital congestion, which compresses compliant structures like the ophthalmic veins. Also, there is an increase in the mucopolysaccharide deposition in the trabecular meshwork. This leads to a decreased outflow facility. Also, they say there's the direct thyrotoxic effect on the drainage through the trabecular meshwork. Some patients are genetically linked and have a predisposition to have both the thyroid disease and glaucoma. This correlation was first described by Wesley as far back as 1918. There is an increased intraocular pressure in all patients of thyroid ophthalmopathy in upgaze, and this is a normal phenomena actually, but it is exaggerated in patients with thyroid orbitopathy. It's termed as the Braille's sign. There is an increase of IOP by 4 to 6 millimeters in upgaze as compared with the primary gaze. It is due to the restriction of the inferior rectus muscle, with severe infiltrative disease, which presses on the globe and prevents the eye from raising up and the eye pressure rises. There is a limited flexibility of the inferior rectus and hence it compresses the globe, causing an increase in the eye pressure. This does not need any treatment. It is more seen in the active stage and it is rarely seen in the fibrotic stage. And glaucoma has been found in thyroid-associated orbitopathy in disregard to the type of thyroid disease that you have. It could be found both in the hypothyroidism as well as the hyperthyroidism. There are studies which say that there is no correlation between the two, and whether it's a chance or true association is a question. The prevalence of glaucoma in these patients, it has been found that there are more ocular hypertensives than in general population. A study in Japan found 24% of OHTs in patients who have thyroid eye disease, vis-a-vis low incidence of say 1.37 to 5% in general population. Also, there was a higher number of glaucoma suspects, and glaucomatous field defects were seen more often in them, and it was usually either an open angle type or the normotensive type of glaucoma. But whatever may be the situation with the actual scenario, but what has been found is that orbital decompression and extraocular muscle surgery may lower the IOP in patients with thyroid orbitopathy by decreasing the episcleral venous pressure. Also, it has been found that decompression surgery may obviate the need for more aggressive management of glaucoma in patients with thyroid orbitopathy. And we should not forget that compressive optic neuropathy is another condition which may produce visual field changes, but the IOP will be normal, and the two need to be differentiated so that as their treatments are also different, and we should not lose an eye because of the compressive optic neuropathy in a patient with thyroid eye disease. So when we are managing these patients, there is a significant reduction in IOP after orbital decompression surgery. We know that inferior rectus recession decreases the intraocular pressure. We can medically manage these patients with higher intraocular pressure with aqueous suppressants, with beta blockers, with alpha-2 agonists, especially if the EVP is raised. And latanoprost can also be a good option. Glaucoma surgery should be considered after orbital decompression surgery, and there would be a risk of choroidal effusion and suprachoroidal hemorrhage in these patients. So in nutshell, why have I put Sadhana's picture there? She, the youngsters may not know, but she was a famous film actress who had thyroid eye disease, and her later films can show the effect in her eye. Now, IOP, coming back to thyroid eye disease and IOP should be monitored in patients with thyroid eye disease. Every IOP rise does not imply glaucoma. Visual fields should be assessed regularly. Treat these patients with aqueous suppressants. Decompression surgery may obviate the need for more aggressive management of glaucoma in patients with severe thyroid orbitopathy. Next, we come to orbital amyloidosis. Although rare, can occur and cause increased EVP. There is a perivascular infiltration of amyloid around extraocular vessels, and this leads to increase in the EVP in these patients. Coming to Sturge-Weber syndrome, the triad of having a port wine stain on the face, leptomeningeal capillary venous malformations, which will come up on the MRI, and the glaucoma, which which these patients present. This forms the triad of Sturge-Weber syndrome, where there are dense episcleral venous plexus which is seen, and there are ampuliform dilatations of capillaries which is seen. This occurs in 1 in 50,000 births. There is a sporadic mutation of the gene GNAQ, and this is not transmitted to the progeny. And there is no race or gender predilection. It affects small blood vessels, capillaries, and this leads to the port wine stain. And for the stain, one can do a laser. One can give beta blockers or propranolol, and the drug-resistant seizures in these patients may be managed surgically by removal of the epileptogenic brain tissue. Coming to the glaucoma in these patients, the gonioscopy shows angle structures appear indistinct with a very high iris insertion. There is an elevated EVP that plays a role in glaucoma in early and late onset type of glaucoma. The episcleral hemangiomas and elevated episcleral venous pressure is present in all of them. Aging changes in the trabecular meshwork, trabecular beams, and secondary angle closure can also occur, which are the other form of mechanisms of glaucoma found in SWS. These patients have a higher episcleral venous pressure, and especially the patients who have glaucoma. The eye which will have glaucoma will have a higher EVP. The eye which has only a port wine stain has been found in a study which was done to be only 9.6. And there were the IOP in the EVP in the contralateral eye was also normal. The veins draining from the Schlemm's canal are part of an intrascleral and episcleral hemangioma. The canal of Schlemm itself may be a part of the hemangioma. And also there are AV shunts in the hemangioma which lead to rising of the EVP, which in turn elevates intraocular pressure. The management of these patients, we have to do an early onset in the patients where there is a glaucoma of early onset. We need to do a trabeculotomy with trabeculectomy, and Dr. Mandal has reported a success rate of 66%. When only trabeculotomies were done, the success rate was much lower. In the patients which present late, one needs to do a trabeculectomy and bypass the episcleral pathway and do this with mitomycin C, which tends to have be like a double-edged sword, because these children end up having very thin blebs, which may make them prone to blebitis, and also because of the sudden lowering, there could be a suprachoroidal hemorrhage and choroidal effusions. Some people do a two-staged implant, the Barwelt implant, or there are people who have done IMED implants also. And all the other types of surgeries which may be needed in these patients is the non-penetrating glaucoma surgeries and the cyclodestructive procedures. The precautions that one needs to take in patients with Sturge-Weber syndrome when operating is that we need to preoperatively reduce the IOP with hyperosmotic agents. We need to placement of posterior sclerotomies prior to entering the eye. We also need to do pre-placement of flap sutures or additional tight sutures during trabeculectomy. We also need to sometimes the use of valved or two-stage glaucoma drainage devices. Also, we may need to do radiotherapy of the choroidal hemangiomas prior to doing the intraocular surgery. There are lower rates of surgical success with this disease, and more intraoperative and postoperative complications are observed in these patients. So we have to be very careful when we handle such patients. Also, patients of orbital varices can have raised EVP. In them, we see an intermittent exophthalmos, and an elevated EVP is associated with either stooping over or valsalvas. In this picture on the side, one can see that the patient is normal on the picture in the left, and in the right, when the person is probably doing a valsalvas maneuver, one can see the filling up of the periocular tissue. And glaucoma, although is uncommon, as venous pressure is typically normal between these episodes. If IOP tends to rise, we can just give them an anti-glaucoma medication, which is very effective in these patients and should be tried before thinking of doing a surgical intervention. Now, also it has been of late, there has been a novel eye drop which is coming up, which is an ATP sensitive potassium channel modulator, which seems to specifically lower the episcleral venous pressure. It also widens outflow channel. It may be useful in patients of normotensive glaucoma and glaucoma associated with Sturge-Weber syndrome. So with the MIGS coming up, there is an interesting role that the episcleral venous pressure and the episcleral veins are seeming to take. And there is this episcleral venous fluid wave, which has been observed in MIGS. So when we increase the pressure within the with the IA irrigation aspiration in the anterior chamber, one can see, as you can see in the center, there is a blanching out of the limbal area. This actually means that the aqueous veins are working well, and they are patent, and can be this. So a patient's inherent drainage system can help us predict when a minimally invasive glaucoma surgery will be effective or not. As Dr. Devendra Grover, who is a proponent of this, puts it, that it tells us when MIGS will become a MEGS, will become a minimally effective glaucoma surgery, is when this drainage does not occur and there is no blanching of the episcleral veins when we increase the pressure within the globe with the irrigation aspiration. So also it has been found that IOP when we do a MIGS, IOP will not fall below the episcleral venous pressure. So it would be good to judge the episcleral venous pressure in these patients, and where you find them where the EVP to be high, MIGS are unlikely to be effective. EVP serves as a physiological backstop against hypotony when a trabecular meshwork based surgery is performed correctly. Based on EVP, one can individualize the surgeries. So if the EVP is high, one should select a surgery where there is a suprachoroidal or supraciliary space for mild to moderate glaucoma, or the subconjunctival space for moderate to severe glaucoma. If the EVP is low, one can utilize the trabecular meshwork Schlemm's canal outflow pathway and provide high effectiveness with minimal hypotony risk. So to summarize, EVP, it can play a role in glaucoma, and in a very diverse clinical scenarios. One should not ignore the prominent vessels when one sees them. Always remember to measure the eye pressure in these patients, not disregard it. And one should take a good history, check for the motility, check if there is proptosis, take a good systemic evaluation, and try to rule out
The video froze, sir.
Meenakshi,
I thought it was my internet.
we can't hear you, Meenakshi.
I think the connection has got stuck. So
Okay.
even the video is not coming, sir.
Can you ring her up and just check?
I'll do that now.
She got disconnected.
So I think anyway, she was right at the end of her talk, perhaps.
Yeah, that's correct. So actually, she brought together a very diverse group of conditions under that one umbrella of raised episcleral venous pressure. And they can be diseases which are so different, and management, depends on whichever disease is diagnosed as the cause of that raised episcleral venous pressure, and of course, controlling the intraocular pressure in the meantime. Any thoughts, Dr. Harsh?
Yeah, I think you're quite right. It is so diverse that everything is actually different. But I think the main message is that one has to look at the entire body.
Absolutely.
But very beautifully presented by her, taking each step by step connection about these things. And so I was wondering.
Oh, she's there.
Sorry, I'm so sorry. I don't know what happened to my.
No,
Was
no,
I
no.
able to? Was I there till the end?
Was that your last slide, the summary?
Yeah.
Good. We got it. And
Yeah.
After that, I was just thanking you for bringing such a diverse group of conditions, which, result in raised episcleral venous pressure and thereby can cause a glaucoma. In fact, most of these conditions are systemic in nature, and one should not be missing out. One should not have tunnel vision and just think about the eye, but one should, approach it in a multidisciplinary fashion, I feel. Sorry, Dr. Harsh, I interrupted.
Yeah, no, we just wanted to thank Meenakshi. I think really you beautifully brought out all the points, and such diverse diseases, very beautifully presented, I think. And I was
Thank
just
you.
thinking, because we were talking and I was asking Vineet about the MIGS. So the MIGS is not going to help, right, in this kind of a situation?
What it actually meant was that MIGS is depending on the EVP, it will be the if the episcleral venous pressure is very high, then the MIGS will not help.
In other words, I think what she's trying to say is that during surgery, even if you've planned a MIGS, if you don't see that aqueous wave where the blanching of blood vessels take place, especially inferonasally, then it's unlikely to help.
And the point is that in all these cases, you have to actually treat the cause. So I think that is very,
Yeah.
very
That is correct. And what you're saying is, in nutshell, MIGS will not work for any patient who has a raised EVP.
Right.
It's a corollary that
Exactly.
EVP can be used to decide which type of surgery to plan amongst the different types of MIGS.
Right.
So that was just a offshoot.
So Pradeep, any thoughts from you?
No, it was beautifully presented, a very, very complicated talk, and simplified very much. The only thing, Meenakshi, it's exciting the people about the episcleral venous pressure is that the people have started talking of the ROCK inhibitor, and there is one mechanism of action that it enhances the outflow through the episcleral venous pressure. So probably, it might excite many PG students as well, because everyone, whenever they talk about the ROCK inhibitor, they talk about the EVP. And you have brought out everything in a so simplified way, though it's very complicated.
So Pradeep, in this case, Pradeep, the ROCK inhibitors are unlikely to work because
No. ROCK inhibitor will not
right?
work. Yeah. Yes.
Yeah. But
ROCK
you know,
inhibitor will not work.
the ROCK
Right,
inhibitors
right.
which have the norepinephrine transporter, they might work because they reduce the EVP.
The norepinephrine transporter, they reduce the aqueous production. Okay, they act through the autonomous nervous system. Okay.
Yes, but the function of it basically.
The episcleral venous pressure is related to the dilatation of the vessels through the ROCK inhibitor. They are the very potent vasodilator.
Yes. Yes.
So if you have a backflow over there, it doesn't work. But yes, it will work through the other channels which it is using.
What do you think, Meenakshi?
Meenakshi?
I think net is not working well.
I actually, are you able to hear me?
Yeah.
Yes, we are. We are.
Yeah. I don't really know. I really don't have much thoughts about ROCK inhibitors and EVP. I'm sorry I missed out on that. So
Anyway, I don't
So
think
I
that
wouldn't
is
be
an
able to
issue in this
clear on
case,
that.
because I think the best drugs will be to reduce the aqueous production.
Yes.
Yeah.
The orbital amyloid was very good. I never saw any patient
Yeah,
so
actually, thank you very much for showing all those things.
far.
It was an eye-opener for us.
Actually, thank you.
Right. So there are a few questions. Can we go through them right now?
Please.
The administrative director.
Sorry.
Go ahead.
Caucasian,
Internet is
an American.
not stable. Yeah.
He had an orbital amyloid, and he used to just complain of a red eye for almost a long time. It was later found that he had an amyloid. So I have actually seen a patient, but when I saw him first, I didn't naturally think it was anything beyond having prominent blood vessels.
Right. Yeah, amyloid in the eye takes various forms. I have seen a case of vitreous amyloidosis. So it's really funny how it can manifest in the eye. Okay, so there's a question which asks, why do episcleral vessels in, say, Sturge-Weber syndrome don't blanch with phenylephrine, unlike as in episcleritis?
Because they don't respond to the autonomous nervous system activity. That's why they don't blanch. There is no vasoconstrictor. They don't have smooth muscles around them.
One is, there are two things why they don't blanch out. One is because they are not superficial. It is pardon me?
No, go ahead.
Yeah, so one is because they are not superficial. Two, because as I just mentioned, that they are actually small hematomas itself. So, and they also talk of some that there were only these blood vessels. I didn't know how to put it, but they said that these blood vessels have only circular muscles in them.
Okay.
So whether that has a role to play or not, I don't know. But it is essentially because the hematoma itself is extending in all the vessels around, that they will not blanch out.
I'm actually very pleased that you made a point about intraocular pressure measurement in thyroid eye disease, where quite often I have been referred patients by saying that the pressure is raised, but when I do it myself, it's not raised. So what is happening perhaps is the patient is looking just slightly up, superior gaze. And so the tightness of the inferior rectus muscle comes into play, and hence you get that differential.
Very right, Vinita. I actually saw this slide.
Actually,
and I had this patient who had everybody is crying 50 pressure, we have to operate, everything else is normal. And so I have got that slide and I show them that the patient is trying to look up and everything retracts and the pressure goes up.
Yeah.
And if you do the pressure by a Perkins while looking down only, the pressure is 12 only.
Yeah.
Very rightly pointed out. And that's very important point.
So quite often they're also saying, oh, it's completely out of control when they're already on medication. It's the same reason. They need to do it in primary position or looking slightly down, because the superior rectus may also be fibrosed for all you know. Yeah, there's another question.
Actually, way back in 2005, I had presented that a case in which there was a thyroid orbitopathy and which had a high IOP, and it was a confusion between whether the patient had a compressive optic neuropathy or a high IOP leading to the visual field changes. So
Right.
that patient had, one could actually see choroidal folds in them and everything. Okay, we'll go on to the next question. Yeah.
So there's a question which asks, how much will carotid massage help in CCF, cortico-cavernous fistula?
Massage.
It does apparently help it does help, as I said, in around 17% of patients who have a high flow and 1 in 3 patients who have an indirect flow. So it does help. Like this patient whom I had shown, he actually just improved on the massage. In fact, we had some 5 or 6 such patients, and it was very boring because each time one did everything, found everything, and sent it to the neurosurgeon. All the neurosurgeon said was, do the massage. Whether they prefer to let the patient go through this before attempting any surgery.
A little unstable connection she has. Are you back with us?
Yeah. Did you hear my answer?
Not the last
I'm so
bit.
sorry.
No worries. The last bit.
So all I was saying was that maybe the neurosurgeons, they prefer to use this, in fact, as a first-line treatment rather than going through the surgical management of a fistula, because this is less naturally not at all invasive. And so they found that patients do improve. What we need to also emphasize is, although literature says in some places that many of them will end up losing vision, but they are very responsive to the aqueous suppressants, and you are able to control the eye pressure, and they don't end up having a very severe form of glaucoma.
Any idea how this is actually delivered, this carotid massage?
I did know it. I'm sure we'll be able to get something. You gently press it. They ask you to turn it and go like this, and generally not more than 1 or 2 minutes. It's actually supposed to be taught properly, and one should not attempt to do it without proper learning, because it can cause severe bradycardia as well.
Yes, that's what I felt. So that was one of the main reasons I wanted to know how it helps.
Probably since it pushes some amount of blood. I'll have to think. I'll have to ask a neurosurgeon. Sorry, I don't have a proper answer for that.
I have one at home, so I'll ask him after the talk, and I'll update you later.
Yeah, you should update us. Actually, I was just thinking. Yes.
No, I actually wasn't aware of this, and this is something I've learned today. So I'll definitely follow up on that. Yeah, I'll do that. Any other points that either Dr. Harsh, Dr. Pradeep, you want to make?
Oh,
No?
There is a question there.
Yeah, there's a new question here saying, idiopathic elevated episcleral venous pressure is congenital or acquired? Idiopathic elevated episcleral venous pressure.
As there are two types in this, either it is sporadic or familial. So
when you
familial
cannot
naturally
establish a
transient-
cause, you mean?
Yeah.
Right, okay. And when you say familial, you're saying there'll be family history? How is it inherited?
Yes.
Ah.
I do not know the pattern, but they said that idiopathic could be either sporadic or familial.
Okay. Fine. That's about it, I think, where the questions are concerned. Time to close. Any final thoughts?
Good night.
I'm awfully sorry about my bad connection.
Don't worry, please. We've had the gist of everything, of your talk, definitely, and also of your impressions and your the answers to the queries. Yeah, so I think we only have a couple of
Thank you so much. It was my
hot
pleasure.
seaters
Inside.
today. Yeah, good night. Thank you so much for your
Thank
time
you.
and your effort. Really